Hi, everyone, and welcome to the 2025 Healthcare AI Bootcamp presented in collaboration by several telehealth resource center partners, a telehealth center of excellence, and many other partner organizations. My name is Lydia Katowski, and I'm a policy analyst with the California Telehealth Resource Center, and I have the pleasure of kicking off today's event. We are so glad you're joining us for this AI journey for our Bootcamp's third live session, AI Applications in Healthcare 2.0. Next slide, please. Before we begin, I'd like to go over a few tips to help you navigate the webinar. You can use the Zoom functions to ask questions, post comments, and connect with fellow attendees. We will be reserving time for Q&A and would love to hear from you via the Q&A function. This session is being recorded and will be posted on the AI Bootcamp YouTube channel by the end of the month. If you encounter any technical issues, please reach out to a member of the CTRC team on this platform or contact us at contact@healthaibootcamp.org. Next slide, please. We would like to thank the Department of Health and Human Services for funding many of the partners who help make today's event possible. We want to note that funding does not constitute an endorsement of any information or content by the U.S. government, and that conclusions are those of the speakers. The information and tools presented are intended for general information purposes only and are not intended or implied to be a substitute for professional, legal, and billing advice. All materials are strictly for informational and educational purposes only. Next slide. Just a note that you do have to register for future sessions to stay on this learning journey. So if you haven't already, we're going to drop a link in the chat and we hope to see you at our other sessions in August. We have a really exciting panel lined up for August 12th. So really hope to see you all at the several sessions happening on that day. We'd also like to thank all the organizations that have made today and the upcoming sessions possible by sharing their expertise and resources. They have really done a tremendous amount to make this entire event possible. Now it's my pleasure to introduce our two wonderful speakers who are here to help everyone further their AI learning journey. First up, we have Dr. Michael Matheny, who wears many hats, serving as the director for the Center of Improving the Public's Health with Informatics, and is also a professor at Vanderbilt University Medical Center in the departments of biomedical informatics, medicine, and biostatistics. He's also a primary care physician within his community and the Associate Director of Health Services Research and Development for VA Informatics and Computing Infrastructure at the Tennessee Valley VA Healthcare System in Nashville. His research sits at the intersection of cutting-edge data science and real-world clinical care, and he has played a key role in the development of the AI Code of Conduct from the National Academies of Medicine. He really is a leader in the AI space, and we're so thrilled to have him here today. Next up, we have Chrissy Kuahine, who is the Director of Clinical and Patient Informatics and Development Director at Waianae Coast Comprehensive Health Center. She has pioneered truly groundbreaking efforts to integrate technology and data-driven care into clinical and patient-facing services with a strong focus on digital inclusion. Talking with Chrissy really conveys her passion for making sure no one is left behind on this AI journey, and her work really demonstrates that passion. She has helped lead a new model for AI integration at an FQHC, which has strengthened Waianae's Coast financial position and streamlined operations. She is a true leader in the health technology space and is committed to lifelong learning. She has served as a voice for low-resource providers around the nation in national conversations, advocating and educating to multiple audiences within Hawaii and all the way to the White House. We are thrilled to have both of these speakers here today, and with that, I will hand it over to Dr. Matheny to get us started.
Well, thank you for that kind introduction, and also to HHS for funding the series, and to the AI Bootcamp organizing committee for the invitation to come and speak. It's a topic that's near and dear to my heart, so let's dive right in. Next slide, please. I have no conflicts of interest in the presentation of any of these materials, and all the funding that I've received in the last 3 years are from federal sources, Department of Veteran Affairs, NIH, FDA, and ARPA-H. Next slide. So, as a biomedical informatician, I've always heard over the last 2 decades of my career that that the complexity and growth of medical knowledge is exceeding the capacity of human cognition to process it and understand it, and that there were continuing challenges. Well, being a data-driven person, I went in search of a good example to give the audience as I presented a lot of the talks that I go to. And I find this to be a really compelling example. So this is an article that was done a few years ago that looked at the growth and the complexity of clinical practice guidelines, particularly in this case for oncology and cancer care. So if you look at breast cancer, prostate cancer, colon cancer, what you see here is that the page length of the clinical recommendations and the scientific reference count have grown almost exponentially over the last 15 years. And sort of really underscore the challenge that we're facing in healthcare and trying to manage increasingly complex patients and an increasingly complex set of knowledge, clinical knowledge. Next slide, please. So another way to look at this is actually the variability of care. So you have a huge complexity in healthcare knowledge, and then you look at the practice patterns. And even among two very straightforward cases where you have a patient who comes in with known coronary artery disease, known atherosclerotic disease, and looking at the first line treatment for that, or statin, or something like atorvastatin or simvastatin, and you look at a huge variability across the country in terms of the rate at which these patients were prescribed this first line, highly like grade A recommended treatment. Also, if you look at bronchodilator use, which is a first line treatment for patients with emphysema or chronic obstructive pulmonary disease, you see a huge variation in the number of patients that are given this. I mean, although the right one is a little bit more context dependent from disease severity, it sort of highlights your practice variability that we really, we would love to leverage AI in order to help us manage. And so we've gone from a world, I remember a world 5 or 10 years ago where we were generating predictive risk models and natural language processing tools, and we had all of these cool toys and cool applications with very little clinical implementation. There were a few cardiovascular risk calculators, there were a couple probabilistic risk models, but there were, hundreds and hundreds of AI development and very few that were clinically relevant and clinically impactful. Next slide, please. And what we've gone to just in the last 2 or 3 years is a completely new world of generative AI-based implementations where everyone is interested in implementing and exploring and using these tools for a variety of business and clinical needs. The problem we have now is that all of these things are being used increasingly, but may not have rigorous user-centered design, may not have rigorous validation, and may potentially be dangerous depending on the context in which they're used. Next slide. And so one of the challenges that we faced over the years with AI in general is once you build them, once you deploy them, and you put them into practice, your job is not done. It's really critical to sort of monitor these tools and surveil them and make sure that they continue to achieve the goals that which they were originally intended to do. This is some work by Sharon Davis in our center at Vanderbilt, showing that these different discriminative AI tools from, oh, I'm sorry, would you mind going back? I may have had it set automatically. These different tools have a very strong susceptibility to event rate shift in the population, to case mix shift, to changes in clinical practice, and they have to be monitored and updated over time. Next slide, please. And so it's also the case that generative AI, ChatGPT, and large language models have some of these same issues. If you look at these tools over time, you can give it queries and prompts, and sometimes those answers change over time, even when the model has not been updated. But particularly what you're seeing in the large tools like ChatGPT is that as new data are brought in to train these tools, then sometimes the answers change. Well, if you're in a clinical application that requires high fidelity for the responses, you can imagine that sometimes this can result in errors and patient safety issues. Next slide, please. And so to sort of summarize a bit, there's a number of implementation challenges that we're facing in healthcare AI. There's issues around integration into workflow at the right time in the right place for the right purpose, challenges in visualizing information, taking what the AI tools are generating and make them represented in a way that is intuitive and useful to clinical users and business users, engaging the relative stakeholders. So we've seen numerous instances in which the patients, the caregivers, and other relevant stakeholders, I apologize, but yeah, thank you, are not engaged, and you end up with a tool that's very useful for some of the constituents under which it was created, but not for all. Next slide, please. And so this is a representation of the work that we did as part of a large expert advisory panel back in 2019 by the National Academy of Medicine, trying to develop a national sort of AI ML modeling lifecycle. And this is really important. This is probably the foundation of this presentation, where we brought together learning health system constructs, user-centered design, implementation science, and human-computer interaction into a life cycle that sort of first identifies the needs and the targets clinically of what you're trying to develop. Second, then develops the tools and processes and systems. And lastly, then appropriately integrates them into clinical practice and into sustainment and surveillance. Next slide, please. And so work that we've done as an update, there was another special publication by the National Academy of Medicine that has just been released in the last few months that seeks to overlay some of the learning we've had in generative AI and discriminative AI in the last few years onto a set of principles that are shared with the learning health system commitments by the National Academy of Medicine and the code of commitments that we hope that developers, stakeholders, healthcare systems, patients, and caregivers can use as a foundation when they're considering developing and using these artificial intelligence tools. Next slide, please. And so I give you this slide mainly to let you know that there isn't just one life cycle, one conceptualization of how tools are conceptualized, generated, developed, and deployed into clinical practice and in healthcare. Some of the National Academy work is really focused on the user-centered design and the implementation science process because we felt like historically that had been underserved. Whereas you look at the international OECD or the new code of conduct that have foci, they're slightly more focused on development as well as implementation and sustainment, which has become really the biggest challenge in some of the current pieces. And so you can go ahead and go to the next slide. And so this, I really want to underscore that, I spent all this time in my career, my early career, developing technical capacity in developing and deploying artificial intelligence systems. But what I learned as I matured in my career is the most important parts aren't the core development. It's ensuring you have the right tool for the right place at the right time for the right stakeholders. And that once you deploy that tool, that you ensure that it continues to do what it set out to be done over time safely. Next slide. And so I'm going to give you a brief example of some work that we've been doing. This is a randomized controlled trial in which we did a clinical summarization tool with the intent to help primary care providers prescribe statins among patients with atherosclerotic cardiovascular disease. Next slide, please. And so statin and high intensity statins, surprisingly, as I showed you in an earlier background slide, remains low in patients in which we know need these medications. And so when we looked in the literature, really these issues are driven by two primary things. First, they're driven by a patient experience of side effects from these tools, and they're also driven by clinical inertia. So once you sort of stop talking about the need for these medications, patients and providers tend to not revisit that and not reconsider potentially using them. On next slide. And in the prior study, we evaluated whether or not patient context aware reminders could improve this use. So that was the purpose of our trial. Next slide. And so, as I mentioned before, one of the first things that's important to do is to really gauge the stakeholders, gauge your audience. And so we recruited a set of patients and with the clinical condition of interest and prescribing clinicians, cardiologists, primary care physicians, advanced practice nurse practitioners, and clinical pharmacists. And we did a series of interviews and surveys to try to understand what issues they were facing, what their perceptions were about what the barriers they were facing in order to prescribe these medicines that are well known to improve patient outcomes in this setting. And what we found on the right is a series of things that we took forward with us when we were trying to design an intervention in order to help improve prescribing in this area. Next slide. And so we recruited a series of 27 primary care clinics in the Department of Veteran Affairs in Texas and in Tennessee. We essentially randomized the 14 clinics to an intervention and 13 clinics to a usual care site. We were essentially looking at the rate of prescribing of high intensity statins between the intervention sites and the usual care sites before and after the intervention. And we developed a clinical summarization tool that would review the patient's chart with natural language processing and structured data analysis, summarize the clinical data, provide a note in the patient's chart, and deliver that to the primary care providers to help their cognitive load in considering whether or not to consider statin prescribing for their patients. Next slide. So this is a very busy slide, but I think it's important to take home that the technical pieces of this are fairly complex. You have structured data management, you have chart review, you have to use large language. In this case, it's a legacy NLP system, but you can now use large language models to process text. You integrate the results of those features, both structured data and text data, into a clinical summary that then you provide into the electronic health record. And so all those things require quality assurance, require safety assessment, and then require surveillance in order to make sure that they continue to function properly, because you're dealing with a patient and provider facing tool that needs rigor and safety. And so the clinicians could opt out of the trial at any time. And we really tried to limit the amount of clinical information that the providers were getting. And so we only allowed them to get 3 alerts for any given time until they had processed those alerts. The clinical summary, as you'll see on the next page, you can go ahead and go on. This is sort of a non patient health information containing synthetic result that showed that we sort of provided these clinical summaries to providers in the patient's charts, ideally 3 or 4 days before they were supposed to be seeing their patient in clinic. But in the end, it turned out that because of the patient case mix and the provider case mix, we were unable to do that. We had about a 33% chance, 33% synchronous, and about a 65 to 70% chance asynchronous. But this is an example of the content. Next slide. And so what we found were that in our practice, we had some clinics that were very high volume and some clinics that were smaller academic practices. And so we were able to saturate the reminders, the clinical summarizations to the providers that had smaller volumes of patients, and were unable to completely saturate and get all the reminders to all of the patients among the high volume providers. So what you're seeing here is we were actually only able to actually provide the reminders to about half of the intervention arm. But and even then, with intent to treat, where we analyzed all the intervention arm versus the control arm, you see a significant increase in prescribing from the use of this clinical summarization tool. We calculated that among those that actually received the intervention, you only need to send out 10 reminders to help a provider get prescribe one statin for a patient, which can have significant impacts in reduction of heart attacks, strokes, and other cardiovascular events. The other thing we found was a process thing. As we predicted, if you gave the letter to the provider right before they were going to see the patient and they were cognitively ready and they wanted that information in order to help their care for the patient, they were more likely to prescribe the statin than if you dropped the note in, a month and a half after they saw the patient and a month and a half before they're going to see them again. We hypothesized that, and the data did bear that out, as well as the fact that people that were had not previously reported side effects. So it was more of a clinical inertia issue of not bringing it up with the patient than it was an issue of the patients tried this, it didn't work, tried that, it didn't work. We also saw increased rates of prescribing among patients that didn't have evidence of adverse events. So using an NLP tool or a large language model to go in and actually extract the adverse events and the safety events from prior attempts at prescribing the medicine gave the providers context for what had happened before. You don't have to go back. You can go on to the conclusion slide. And so I hope that I was able to sort of just, it's a bit of a whirlwind, but I hope I gave you good references. So the National Academy works at the beginning are great references for overviews of artificial intelligence in healthcare. They're being increasingly integrated, but I think our challenge now really is to slow down a little and take a rigorous approach to ensuring that these tools are appropriate to the context of use, that they're deployed, and that they have surveillance and maintenance systems in place to help make sure that they are safe for the providers and the patients' use. I think it's important for everyone, as you're facing artificial intelligence in your practice practice and your care, to ask your leaders, to ask your healthcare systems, to ask, okay, you've implemented these tools. Do you have any safety surveillance? Have you done any evaluation for whether or not the tools were considered for the appropriate clinical workflows or context of use? And I think all of us have a shared responsibility to help our healthcare systems, our practices, our organizations really engage in best practices around healthcare AI deployment. Last slide. Just small acknowledgement. You can go ahead and click, I think, 3 times. Um, yeah, there you go. One last time. And so I would be remiss if I didn't acknowledge my PI, Salim Virani, on the statin trial, and a large number of other collaborators across Dartmouth, Vanderbilt, and other institutions that have engaged in artificial intelligence and machine learning work, as well as my funders of my research of various projects over the years. And so happy to answer questions at the end. I think we're doing both sessions in back to back, and then having an open discussion session at the end. So thank you very much for your time. Next slide.
Thank you, Dr. Matheny, so much for that wonderful first portion of today's conversation. I think you set the stage so well for lots of different contexts of and applications of AI in healthcare. And now we're going to get a really specific insight to some very specific conditions of deployment with Chrissy. So, Chrissy, with that, I'm going to hand it over to you for our second portion.
Awesome. Well, aloha kako from Hawaii, Oahu, Hawaii. Mahalo, first of all, for the opportunity to share what we've been doing around AI and how it's helped with our decision making, and more so with our being able to care for our patients in a holistic and even in a targeted fashion. And then, listen, I have to say mahalo to Dr. Matheny. He did an excellent job in sticking to his 20 minutes. So I'm gonna try that myself. And he laid really a good foundation for what we see are challenges in terms of lots of data and how do we manage that and leverage it in this AI world. Next slide, we can go ahead and lay the foundation. Oh, I have no conflicts of interest. We can go to the next slide. So I'm out here on the west side of Oahu in the state of Hawaii. We are a federally qualified health center. We've been around now. This year will be 53 years. And what I really love about this, this picture is it illustrates our growth. We are located on the side of the island where there's only one road in, one road out. And if you look at the map there, I don't know if most folks know, but you can't go all the way around Oahu. And so that in itself presents some geographical challenges. If you look at the amount of patients we serve, so this is our health center UDS reporting, over 35,000 unique patients. We have our in-person, and we also offer telehealth services. I think what stands out here is the majority of our patients are of Native Hawaiian descent. And so we are always having to make sure that we're culturally sensitive in the kind of services that we provide and how we provide those services. Next slide. So seeing that, we have to take into consideration not only the health indicators, those chronic conditions that impact our patient and our communities, but we're also cognizant really of the Native Hawaiian culture and heritage that's woven around all of that. And so having to address those significant health challenges while also understanding the historical and systemic disparities that have impacted generation over generation. We have over 50,000 residents on our side of the island who, again, I had mentioned are predominantly of Native Hawaiian descent. I think notably for our patient population, if you see here the socioeconomic data, over 70% of our patients live at or below the poverty level. You can see there who are on Medicaid, who are uninsured or have dual. The community health indicators here, and I labeled that incorrectly, that's actually Waianae, not, so this talks about our entire community. And if you look at the obesity and diabetes prevalence, it's unfortunate, but we're number one in both our Honolulu, our city and county, Honolulu County, as well as our state. So almost double in obesity prevalence, and then diabetes. And then we can't forget about our cultural heritage and that aspect. And so next slide. And so how has AI helped us? And what does it mean? How are we using that as a tool? And that's exactly it. So augmented intelligence, artificial intelligence, really it's a tool that we've used, and it's not a replacement for any of our staff. It's not a replacement for the kinds of services that we provide, but it's definitely given us a way to provide a comprehensive, accurate illustration of the population that we serve, marginalized community, high-risk community, uh, in ways that we couldn't before, right? So we have data to prove that this kinds of services that we provide are truly making an impact, and that the patient population we serve are really at higher risk than those in other communities. So it allows us to be proactive and not just reactive. And you'll see at the end of a couple of my slides how we use it just really in practical ways within our clinical teams, to help better support our providers and our clinical teams. Next slide. Okay, so we didn't just start using AI. It's not like you plug something, turn on a switch or plug something in the wall, and then you have all this great AI, information that's analyzed, and you have this great AI input. And so really the foundation, I think this is probably the most important part of my presentation, because I know folks get excited about how you can benefit from AI and leveraging technology, but you have to have really a good base for it, and that's the data. Right. So number one, I'm always going to start off with, you have to have your staff buy-in. You have to have those that are going to be directly involved, have a good understanding of how you're using the AI and how it's going to impact the work that they do, how it's going to benefit. I mean, that goes without saying for any kind of new change process. What's really important to know is that you have to have the data. The only way that AI works is it has to have this data input from various sources. And I'm going to say, I mentioned that we've been around for 53 years. For decades, probably about 30 years. I've been here for 35 years. And so for at least 30 years, we've been already collecting the amount of data that was not or is not even now typically collected by our payers. And so what I mean by that is called enabling care services. So it's those wraparound services that we provide as a FQHC, that many do, that are not recognized on the payer level, right? So they're not on claims, you don't get reimbursed for them, but we know they contribute to our patients' overall care and well-being. So things like transportation, sitting with the family, explaining why is it that their grandma or their mom has to go for a referral in town, and then having to coordinate that transportation. That all takes time, and it does contribute to whether or not there is going to be a good outcome. So we were able to structure that data so that we could audit it. So each of those types of services are codified. So if you think, for those that are familiar with CPT codes, we've codified all those services into numeric codes that we're then able to turn into structured data that we're able to report on, and of course now add into our analytics. The other thing is our prepare surveys, our social determinants of health surveys. We're able to take that data and add that into our AI model, as well as Dr. Matheny mentioned NLP. So we use natural language processing on our case management notes and put that in. And I think the beauty of it is that we've been able to communicate and negotiate with our payers for them to deliver to us on a monthly basis our patient claims data. And so this is something that we get monthly, not every 6 months, where usually by that time that data isn't as important or not as usable because it's been so long. Next slide. Okay, so just very quickly, for those that maybe are not familiar with how AI is being used in really the steps, and I think the most important thing that we've been able to really leverage and take advantage of is that prescriptive analytics. So I think we're all familiar with descriptive analytics. What AI is able to do, though, is take these larger data sets, as Dr. Matheny talked about, and be able to formulate something that it would take hours or multiple data analysts to do. And so you're able to come up with ways to identify certain healthcare trends, whether it's in your community or organization. The other one is diagnostic analytics, right? So then at that point, once you see these trends, you can come up with understanding of why, what impact and why is that occurring. So obesity prevalence, diabetes prevalence. The predictive, you can identify those patients who would be more at risk for either developing chronic disease, maybe higher risk of hospitalization. But I think the beauty of it is the prescriptive part, right? So if you can identify those that are higher risk for poorer health outcomes, but imagine if you could identify and really get laser focus and target on those activities or interventions that would have the highest impact in terms of improved health care outcome. And then, of course, the side that we always have to remember is the cost savings. How can we do all of this while managing the cost of healthcare? And then, of course, there's that whole data processing that is now available that wasn't available in the past without AI. Next slide. So, if we think, what I like to share is how we've been able to identify more accurately, not only our patients who have been assigned to us by our peers, who are not only at higher risk, but those that are most impactable. And I think we've actually coined this. So we have a risk score as well as an impactability score. And then we've been able to take all the data that I mentioned in my earlier slide, run advanced analytics on it, and come up with truly a relative risk coefficient. So if you think about the traditional model that payers use in order to identify a patient's risk, so if they're at risk of poor outcomes, risk of hospitalization, they're going to use the traditional CMS HCC risk scores. What you're seeing here is based on our patient cohort. And if you look at the different, and this is diagnostic, and then we take into consideration also the social risk, and we're going to see that on the next slide. But if we look at and focus on schizophrenia, for example, in a CMS HCC model, a relative risk score for schizophrenia is going to be a 0.524, so 52% chance that that person will have some negative impact or outcome because of the diagnosis. Now, when we take into consideration this AI advanced analytics with Foresight Health Solutions is the company that we work with to use AI to predict risk in a way that's more comprehensive, we come up with a relative risk coefficient of 0.6. And so remember now that takes into consideration from a holistic approach, not only the diagnosis, but what other social factors are going to impact that person's diagnosis. So that really is, if you think about it, that critical insight that we didn't have before, right? There was no way for us, it was very difficult to really take into account all the elements and factors that we all know, right, that impact a person's health outcomes. And so we're going to go to the next slide and look at how that impacts. So when we talk about the social factors, right, so we think about those things that we know impact how a patient is going to take care of themselves. So we'll focus on transportation here. So with transportation, there's a Z code for it. So I don't know if folks are familiar with ICD-10 codes. There's thousands of them. Transportation has a Z code, but it doesn't have a risk score. And our peers are not looking at whether or not a patient who has chronic conditions, whether or not what the impact is if they don't have transportation. I think anecdotally, we all know, right? If you don't have transportation, you're not going to show up for an appointment. That leads to delay in care. There might be higher ER utilization. So imagine if you can take all of that, factor that in, and you come up with, again, a truly comprehensive, accurate illustration of the patients that you are serving. And then you're able to come up with the different targeted actions that are going to have the most impact. So getting our patient with schizophrenia, making sure that they can show up for their appointments, that they have transportation. It sounds easy, but if you have a whole group of patients, a whole patient population, and you're not factoring that in, that may be something that you're missing. Next slide. NLP, so this natural language processing, it's not a new technology, but it's been something that's certainly been helpful in helping us to extract even more data to enter into our AI model. And so what we found here during COVID, it was very interesting. Although we were presenting our patients with social determinants of health, our prepare survey, a lot of them during COVID who had been working all that time lost their job and that were now facing food insecurity or housing and other resource utilization insecurities were not uh, uh, in Hawaii, they were a little bit ashamed to admit that that was what they were having issues with. What we found though, once they got connected with a case manager or a community health worker, that talk story in Hawaii, we call it talk story, where you open up this level of trust relationship. And that's where that information about having difficulty in getting food or having difficulty in paying the rent, that all came out, but that's all in narrative. That's all in our caseworker notes. And so with NLP, we're able to, based off of specific words, able to extract that information. And you can see here with unemployment, the SDOH survey in blue shows what the survey data showed, right? That they're having employment issues. Once we use NLP, that went from 540 to 604 patients that were actually impacted by employment issues. And then you can see that for transportation, food insecurity. Next slide. And so what has the impact been for us in terms of financial and operational? I'm going to say it seems laborious in the beginning to collect all this data. And we find that as a challenge for other health organizations that we're trying to help to get on board. And maybe not even just for, take away the AI advanced analytics part of it. We all should want to, right? Especially with FQHCs that are, we're always slim on resources. We're always having to think, really innovative to make sure that we're caring for our patients and we continue to care for our patients regardless of what's happening at the federal level. So why not turn those services that you're providing, but on the data frontier, they're invisible, right? Because you're not capturing in a way that you're able to show its value. And then you lose out on negotiation with your payers on negotiating contracts. So really what you should think of in the very beginning is, what is that return on investment when you can capture the services you're already providing, but also use it to your advantage, right? And then the second part of it is then it strengthens your negotiation with your payer. We've been able, with our first year when we piloted this with 2 of our Medicaid plans, we were able to deliver a cost savings of $3.5 million. There was a 16.4% reduction in total cost from baseline, and we were able to negotiate with our other payers on what our CEO likes to call a grand bargain, where we're able to then now share those cost savings with the payer. So whatever is left in that risk pool pot, we get half, we put them back into our programs, we put them back into operations, and then the payer walks away with a savings there as well. And so finally, I think what's most important about this is because of that targeted, the ability to target and really get laser focused on those actions that are going to be most impactful for your patient's care. You reduce those ER visits, you reduce those hospital admissions, and you improve healthcare outcomes with fewer acute episodes. Next slide. And so next, yeah. Before I end, I also want to say, besides the AI model, and if that for some might be daunting, you may not have the data yet, and you're still at kind of that first tier stage. There are other ways. AI is already impacting how we deliver care at the front line, right? So we're using Tidal Care. It's a device that can be used for remote physical exams, for those of you that are familiar. But what they've done is they've embedded an AI-powered algorithm that then listens while the device is listening to breath sounds. There's an AI algorithm that can help to detect wheeze. So it's a clinical support decision tool for the provider, who again is remote, so they can be miles away. But as they're listening through the device, the AI algorithm can not only point out whether or not there's a wheeze, but that level of wheeze. Next slide. And I think Dr. Matheny in his presentation mentioned ambient technology. And so we have implemented Dragon ambient technology. If folks are familiar with Dragon, they've first rolled out with their voice recognition. With ambient technology, your provider can sit with their patient, look at their patient, and really stay engaged in what we remember back in the day as really true that patient-provider interaction. At the end of the visit, that AI, really the beauty of it is the AI takes the context of the whole visit and then is able to put it into a SOAP note that the provider then all they need to do is review it, make any edits. In terms of accuracy, I actually rolled this out with our providers. Amazing. I was in an exam room with patient, provider, wife, and myself as I'm rolling this out and helping with any technical issues. The AI was able to focus on patient provider conversation while at the same time I'm having a conversation with his wife. But the note was beautiful, very minimal intervention from the provider. So you think about addressing provider shortage, provider burnout. And last slide, I believe. Yeah, here we go. So when we talk about AI, we always have to remember, and this has come from my community, right? So human first, AI supported. I like to think of artificial intelligence as augmented intelligence. It's never, and I think Dr. Matheny studies, we're not near anywhere where it's going to replace any provider's decision making. But we also have the challenges of making sure that it's culturally sensitive, making sure that your large language learning machines are not biased. And then we also need to, the only way that this is going to work is you have to have buy-in, staff level, of course, at your leadership level as well. And so I am open to any questions, happy to share, what our lessons learned and how we got started. So mahalo, appreciate the time.
Great, thank you both. Both those presentations, I think, represent the continuum of issues that we're facing. I'm Sylvia Trujillo. I'm the executive director of the California Telehealth Research Center. And we already have a number of questions queued up from you from our panelists and others that have been sent in earlier. So the first question, and I believe this is I think both of you could respond to this. With the advent of AI, how would you describe the research and findings using randomized clinical trials done conventionally versus how potentially AI could be used in order to really address the discrepancies in clinical care that could be significant? So in a nutshell, I think what this participant is really getting at is how can AI transform and change what has historically been randomized clinical trials that can be prospective or even retrospective analysis. Can we move closer to a real world data environment where we're getting real world evidence in a continuous learning system? Does this get us one step closer if we deploy AI? So I'm going to send it to Chrissy first and then Dr. Matheny.
Let me see, my screen is not responding. Hold on. Do you hear me? Okay.
We do, Chrissy.
Okay, good. I'm going to say, if I'm understanding the question correctly, I mean, in real time, how we can assure that what we're receiving is accurate, and then address any discrepancies. I think we're headed that way. What we found, at least in our AI advanced analytic model, you still have to have validation and verification, and that's for sure. So at the payer level, we've used their actuaries. They've actually gone and gone through our results based on our AI model, and they've supported the findings within a less than 6% error rate. And so, if you think about the amount of data And then in our case, the cultural sensitivity, there's not a whole lot when it comes to Native Hawaiian culture. Um, and so we've been able to build our learning model around that so that we can address those things. But there's certainly the validation and verification that needs to happen.
Michael, how
Thank you.
about you?
And yeah, so I will answer with three brief comments because I'm trying to triangulate the intent of the question. So you know, I think we're living in an era where more and more data are being collected, and there's a strong opportunity for, pragmatic clinical trials and for setup of design where you have equipoise between two things. You can't afford millions and million dollars of a rigorous clinical trial, but there's a lot of opportunities now to leverage the electronic health record and the data ecosystem to sort of randomize and sort of test out things in a continuous learning healthcare system context. It doesn't necessarily just mean AI, although I think testing AI tools will be a really important part of that sort of infrastructure. The second thing I'll say is I think, real world data and real world evidence, there's an opportunity to use observational data. AI learns from observational data in order to help continuously improve clinical care. I think certainly there's an opportunity for AI and the growing real world data ecosystem to lower the requirement for clinical trials, although I think there will always be a place for a certain set of equipoise, a certain set of situations that you just can't really get at except through a clinical trial. So I'll leave it there, but I hope I answered part of the question.
I think you both answered different aspects through different lenses, which is the benefit of having these types of sessions. I want to follow up. As you think, Michael, about the level of training that your staff and other staff may need when you're deploying AI systems, thinking back to when you first started on this journey, how much training is needed in order to ensure that these tools are being used appropriately, and what were some of the challenges or hurdles you faced through that journey and that you face even now? And then I want you to, it's a compound set of questions. So, what are the challenges around training? And as you think about low resourced environments, what are opportunities that they should avail themselves to make that stretch into increasing the literacy and competencies with regard to AI? And then I'll repeat the question for Chrissy.
Okay.
Aloha, so sorry about that. I
No
lost
worries.
connectivity. Okay, great.
Come back to you. Okay,
Uh,
Michael.
all right. Yeah. So I think there's a couple issues. So one is, how do you train end users to sort of use AI technologies? And I would say, in large part, if the system is working optimally, you have a set of best practices, you have a sort of a framework, you have an organization that helps ensure the appropriate use of the tools. Whether that's internal or in lower resourced environments. You can have external third-party vendors and consultants and experts to help. I think democratization of AI technologies is a really big issue right now because we haven't worked out all of the costs and the scaling and those pieces. So that being said, it's really on everything around the clinical user. Ideally, you don't want a AI tool to be brought in for you to have to use as a business or a clinical user that hasn't already had robust user design, hasn't already sort of been integrated into the normal clinical cognition that you are already interested in doing. Those things can be disruptive. They can reduce patient safety, and the users will end up not really effectively using them. So I think the other question around the other caveat around training is right now so AI is not fully mature. The example I like to use is the lab tests. Like, now we've got CLIA certification for laboratory testing where, I order a creatinine or a basic metabolic panel. I don't actually know the assays and the chemicals and the normal range and the hardware that's used to do the calculations. I trust that certification has created a safe environment environment for me to interpret and use that data. AI is not in that place yet. So I think the user community and the health system leaders and the system has a higher responsibility for checking and ensuring that best practices are done as the domain matures towards what we hope is a steady state with, where you don't have to worry about that as much in the future. And I'll pass the baton.
Yeah, that's a great segue. Chrissy, I'm gonna sort of leapfrog because you got a specific question about how Waianae Coast made the decision to use, for example, da the DAX Microsoft Dragon product, and this would be true for like any product. What are the factors and processes very related to what Michael just said, when you're making that type of selection? What factors?
I'm going to say that this is going to go back a few years, 20 to be exact, when we implemented our EHR system. And that was a huge shift, obviously, from paper to electronics. And at that time, our CFO said, whatever it takes to help our providers continue to see their patients for uh, and make sure that their focus is on their patients. I mean, Dr. Matheny, you didn't go to school to be a data entry person, right? In terms of your MD, you went to become a provider so that you could care for your patients. And so that has always carried forward. So we were always looking for tools to make sure that our provider could see their patient, but also still had to be, especially as a FQHC, cognizant of our reporting requirements. Unfortunately, that never goes away. And then even out of a FQHC, you still have to, I mean, as a provider, right, Dr. Matthew, you know that you see your patient, and especially if they're complex, the only way that your top level folks are asking if you can make sure you document in terms of ICD-10 codes accurately for everything that your patient has. We know that time constraints takes that away. So with DAX, that just ended up being yet another tool. So we started with Dragon, voice recognition, and then when Stacks was introduced, that was a way for providers to really get back and be connected. And again, when we talked about, it's not that we can let it, our providers can't just use DAX and then not review their note and move on to the next person. You still have to review it. There's still, context that AI misses and that you still have to do, again, like I said earlier, that validation and verification. But overwhelmingly for our organization, I can say it's helped our providers tremendously, and we have more and more coming on board. And then really there's the trusting. That has to be, do I trust this AI? Do I trust the technology? And I think what our providers are finding is that it's definitely a whole lot better than when Dragon Voice Recognition first came out.
Great. That is super helpful. So we have time for one more question, I think. Um, but essentially, when you were thinking about how are the staff adapting to the use of the new software, I think this again, we're getting lots of questions around the implementation science. So what happens in terms of the nuts and bolts of training for staff? What is the basic level of training? Or Mike Michael, does it really simply rest on when you, as the provider organization, are evaluating whether it's appropriate, both for the need and for the conditions of deployment? Like, that's done. You don't need to worry about training. What training, if at all, was needed to adapt these tools into practice?
Yeah, I can just briefly. So I think anytime you're changing the workflow or the cognitive load or the or the results or the interventions, the pathway, you have to do training. I can't tell you how many times in an electronic health record that I've worked in, they change the user interface, they move an order from one place to another, they change a template, and then you're disoriented, and then it costs you time and cognitive load. So I think it is really important, no matter what you're doing, whether that's an AI intervention or just a flow sheet or a clinical probabilistic or deterministic clinical decision support, to sort of orient and try to outreach to the users of your tool to help them understand the changes and the uses and the caveats of that. So I think that's a general implementation science framework that thankfully we can use for a lot of the AI that we're interested in bringing into healthcare. I don't know if that fully answers the question, but I'll leave it there and pass the baton.
Yeah, I'm gonna say one thing that we didn't talk about is, if you know, at least from uh, uh, implementation, identifying those that are interested in helping through get folks using AI and technology in general, is having those providers that are interested and have some basic understanding of how AI is is getting better and how we can certainly leverage it, not only in the exam room, but at an organization level. And so I've recruited those providers to help, for example, when we implemented DAX, because there's a learning side on the AI side, right? It's continuously learning. It's definitely getting better, but it needs humans. And when we talk about patient summary, I think Dr. Matheny, one of your presentation slides, we are still working on a patient summary that's AI generated, but some of the, going through the notes and what is presented to the provider, a lot of it is not really pertinent when it comes to just getting a quick snapshot of the patient that you're going to see in the next 10 minutes. And so there's still definitely a whole lot of massaging, but it's going to take people like a Dr. Matheny, providers who have the ability to do the training and the teaching of this AI model to make sure that they're involved every step of the way. So that in itself can be a whole big challenge, is what I found.
That's a wonderful ending point for us. I want to thank you both for your expertise and in our effort to democratize AI for rural, under-resourced, and even organizations that may have lots of resources, but this is a field that is changing weekly. So with that, I'd like to hand it over to Lydia to wrap us up.
Thanks so much. And I just want to echo thanks for our wonderful panelists today. Learned a lot, and I'm sure our audience did too. So as we conclude for today, I want to invite everyone to complete a short exit survey while I go over our upcoming events. On August 12th, we will have some hybrid sessions taking place that you can access by registering at the Health AI Bootcamp website. And those will be 5 45-minute hybrid sessions covering several healthcare topics. There's a few questions in the chat that got at some of the topics that will be addressed. So if you didn't get your question answered, or maybe you heard questions and thoughts that really sparked some additional questions, we highly encourage you to join us for those sessions in August. We will be dropping the link to the registration page in the chat so you can access that there. Additionally, you can view recordings of all previous sessions on our YouTube channel, which will also be dropped in the chat. And I can see responses rolling in for our survey, so I really appreciate you giving us the feedback. As we conclude, I just want to give one more thank you to everyone who helped make today possible, our partners, our speakers, and our attendees. We hope you enjoyed this session, and we look forward to seeing you again in August as we all continue on our AI learning journey. Have a wonderful day.